In my current role, I no longer work for the National Health Service. I used to be the principal pharmacist in the Department of Community Psychiatry at Clatterbridge Hospital on the Wirral, but I now run a freelance consultancy business. The majority of my work is in continuing medical education, and I provide teaching either directly or as resources for consultant psychiatrists, for trainee psychiatrists, for nurses, pharmacists, social workers, and even, believe it or not, for solicitors, all of whom work in mental health care. The other part of my current work is in research, and I'm currently engaged in a national research project which is investigating the cost of relapse for people with schizophrenia. Dementia is an area of healthcare in which there is huge unmet need. There is currently no cure for dementia. There are various approaches that might be used to help people with dementia. Some of these approaches may include some psychological interventions. Some of these approaches are purely about behavioural help for people with dementia, and some of these approaches involve the use of medicines. The problem with the use of medicines is that many people develop dementia in late life, which means they already have a number of other conditions that might also need the use of medicines for its treatment. For example, they may have heart disease, they may have high blood pressure, they may have problems with cholesterol, that sort of thing, arthritis and so on. And it becomes more and more complex trying to find ways to use medicines which are compatible with each other, and also trying to monitor the outcomes of the various medicines that people might be taking. And this is where a specialist mental health pharmacist can come in. Specialist mental health pharmacist will have much greater depth of knowledge about the condition that is being treated, in this case dementia. But they'll also be aware of the other conditions that the patient might be experiencing, and they will be able to give specialist advice about the choice of medicine, about the monitoring of the outcomes of that medicine, about how to avoid side effects, how to manage side effects if they do occur, and which medicines they might or might not be compatible with. So it's a very important role. People often ask, how can medicines help in dementia? And I think it's important to be honest and say there is no cure for dementia. What medicines can do is to delay the progress of the illness. What that means is the earlier we can detect the illness, the more benefit that you are likely to receive from taking one of these medicines. Currently in the UK, there are 4 medicines licensed for delaying the progress of dementia. 3 of these medicines are used in the earlier stages, and one of these medicines is available for use in the later stages. The problem that we face is that it's impossible to know in advance which medicine a person is going to respond to. My view is that the best way of choosing a medicine as the initial choice is on the question of side effects. Which side effects are most important to the individual who's taking the medicine, and which medicine is least likely to cause that particular side effect. Having said that, the choice is not extensive, but there are still options available around which we can make choices. One of the things that we have to do, or at least try to do, when we are offering people with medicines for dementia is how do we monitor how well they're doing on this medicine. We can't predict how fast the disease is going to progress if it remained untreated. So how do we know that the medicine is actually delaying the progress of the disease? And that just requires careful monitoring. We expect the medicines to slow the progress, not to halt it. And for some people, the rate of slowing will be much greater than it is for others. My view is that the progress of dementia is such a devastating thing to happen to somebody that any amount of delay is worth having. The downside, of course, is side effects. And for all medicines, there is always a judgment that has to be made, a balance around what is the benefit that I'm going to obtain from taking this medicine, and is that benefit worth the cost that I'm going to have to pay in terms of side effects. The only person who can actually make that judgment is the person taking the medicine. And I want to say a little bit more about how we should make choices in relation to taking medicines for dementia. Currently, there are 4 medicines available in the United Kingdom for the treatment specifically of Alzheimer's disease. Although there are other forms of dementia, there aren't medicines licensed for use in these conditions. However, Alzheimer's disease itself is not, shall we say, a pure condition. All dementias tend to be mixed. So if you have a diagnosis of Alzheimer's disease, it's likely that you also have at least some contribution to your dementia coming from vascular changes in the brain. These are changes in the blood vessels in your brain which can cause dementia. If you have a diagnosis of vascular dementia, so the clinicians who are treating you feel that the major contribution to your dementia is because of changes in the blood vessels in your brain, mini strokes is often the way that it's put. It's also likely that you will have some component of Alzheimer's disease as part of your overall picture. If you have Lewy body dementia, it's likely that you'll have a mixture of both Alzheimer's, a mixture of vascular dementia, and also an effect on what's called the Lewy bodies in the brain, which mean you can have aspects of Parkinson's disease as part of your dementia. However, when it comes to clinical trials, regulatory authorities insist that you must have a very specific condition. And so the specific condition that has been researched is Alzheimer's disease. As I'm sure you're aware, the brain operates through electrical impulses. These electrical impulses are generated by chemicals that we call neurotransmitters. One of these chemicals is called acetylcholine, and acetylcholine is the neurotransmitter that is implicated in Alzheimer's disease, at least in the earlier stages of Alzheimer's disease. The brain cells or neurons which rely on acetylcholine start to degenerate. And it's this early degeneration of what we call cholinergic neurons that affects memory loss, particularly short-term memory loss. 3 of the medicines that are available for the treatment of Alzheimer's disease, galantamine, rivastigmine and donepezil, have an effect on acetylcholine. And what they do is they stop the body from breaking acetylcholine down after it's been used, so it stays working for longer, even though the nerve cells that are using the acetylcholine themselves are degenerating. So essentially it's boosting this natural brain chemical acetylcholine to try and slow down the rate of memory loss. You might expect that because these medicines essentially do the same thing, their effects would be identical, but in fact they're not. And people do have individual responses to these medicines. So you may respond well to one, but not to another. So if one of these medicines doesn't work, it's still worth trying another one, and then the third one if necessary, to see if we can find one that does work for you. The 4th medicine is called memantine. Memantine shouldn't be used in the earlier stages of Alzheimer's disease. Memantine has been shown to delay the progress once you've got to the more severe stages. I'm sure that if you have a relative or somebody that you care for who is going through the process of evaluation in dementia, you'll become familiar with a scale called a mini mental state exam. The mini mental state exam has a score that goes from 30 at best down to 0 at worst. And the earlier stages of dementia, the mild end, would be a score of between 20 and 30. So it's in this area that we would want to use drugs like galantamine, rivastigmine and donepezil. When we go below 20 down to about 14, we would say that that's where you have moderate severity of Alzheimer's disease. And those three medicines could still be used in that moderate area. But as we start to approach the cutoff of 14, that's when we would consider using memantine instead. And going down from a score of 14 to about 10 is where we would think to use memantine. Once we've gone past a mini mental state score of 10, there doesn't seem to be any benefit from continuing to use these medicines. And it's most likely that once the person with dementia has reached that level of severity, the clinicians involved would recommend stopping the medicines because the person isn't getting any further benefit from them, but they will of course be at risk of side effects. I think one of the most important issues that we face in relation to the use of medicines is how can people make the right choice for them. I think there are 4 aspects of information that people need to be provided with in order for them to be able to make properly informed choices. The first aspect of this is the question of what will happen if I take no treatment at all, and what difference will taking a medicine make? That's a difficult question to answer because people are very different in how quickly they progress with dementia and particularly with Alzheimer's disease. And of course they also vary in how they respond to the different medicines. But what clinical trials do tell us is there is a clear difference over a course of 6 to 12 months in terms of the slowing the rate of progression of Alzheimer's disease if you take these medicines. The second question that we need to provide the answer to is how well are the medicines likely to work and how do they compare with one another? Well, it's impossible to give that answer on an individual basis. I can't sit with a person who has dementia and give them a categorical guarantee that the medicine will work or how well it will work. What I can say is that clinical trials show us that we get response rates of approximately 50 to 60% of people who take these medicines, which is similar to other medicines used to treat mental health problems. If you don't respond to the first medicine, then it's worth trying a second medicine because there is a possibility that even though the first medicine didn't work for you, the second one may well work for you. How do these medicines compare with each other? Well, there's no real difference in terms of the outcomes of clinical trials between the 3 medicines that work on acetylcholine, as you would expect, because they are in fact essentially doing the same thing. The difference lies in their side effect profiles, and that's where choices really should be based on. And I'd like to say more about their side effect profiles in a minute. The next element of choice is to have information about what's likely to happen if you start one of these medicines but then stop taking it. Health professionals sometimes have a term for this which they say is non-compliance. Sometimes they call it adherence. I don't think it really matters what you call it. But it's important to be aware that no medicine works if you don't take it. The balance lies between the benefit that the person taking the medicine obtains from it and the side effects that they experience. And it's not uncommon for a person to say the side effects are actually not worth the benefit that I'm getting from it. And if that is their choice to stop taking the medicine because the side effects are intolerable, I personally believe that's perfectly fair for them to do. and if that happens, then we need to try and support them in that decision, rather than to try and impose our ideas of whether they should or shouldn't continue to take the medicine. The traditional way of taking medicines, of course, is to take a tablet. The problem is that in dementia, sometimes people lose the swallowing reflex and they find it difficult to swallow. So are there any options available for people who find it difficult to swallow? And the answer is yes. Galantamine and donepezil and rivastigmine are available both as tablets or as a liquid, which makes it easier to swallow. The dose of liquid could in fact be put into a drink if you wish. Memantine is also available as a tablet or as a liquid. With memantine, the liquid comes in a pump, and you literally just pump the dose of liquid and put it into a drink or onto a spoon for somebody to take. Rivastigmine is also available as a patch. Now, you've probably heard of nicotine patches that people use to try and help themselves to stop smoking. It works in exactly the same way. The patch is simply applied to an area of clean, dry skin, and the medicine that's in the patch is absorbed through the skin over a period of 24 hours. The first thing to remember about side effects is that all medicines have side effects. No ifs, no buts, no exceptions. You might think that a bottle of cough mixture that you buy for a child down at the chemist is not going to have side effects. Wrong. Think again. Even herbal medicines have side effects. One of the examples that I often give is a herb called digitalis, the common foxglove. The foxglove contains digoxin, which is used in the treatment of heart conditions. But a large dose of digoxin can prove to be fatal, the worst side effect of all, and that's from a herbal medicine. So make no mistake, all medicines have side effects. The good news is that not everybody gets them. And we tend to think of side effects as being very common, but they're not as common as we actually think in many cases. And the best way to find out about whether side effects are likely to be common or not is to look at the information that comes out of clinical trials. When we look at the side effects for the medicines that treat dementia, we come out with a list that is literally as long as your arm. But the important point is that most of these side effects are rare or uncommon. There are some side effects that are common, and I'm afraid I have to refer to my crib sheet here because there are too many of them to remember. The most common side effects are side effects that affect your digestive system. So commonly nausea, vomiting, decreased appetite, some weight loss. You may also have some abdominal pain, you may have diarrhea, and you may have some excess stomach acid. Now this sounds like a lot of side effects, and of course sometimes they can be severe and sometimes they can dramatically impact on a person's quality of life. But overall, the risk of these side effects from clinical trials suggests that it's less than 1 in 10. What you need to remember is the likelihood of not getting that side effect is 9 in 10. Other common side effects include agitation, depression, and hallucinations. You may have some anxiety, some confusion, and of course it's difficult to differentiate between confusion caused by the drug and the confusion that's caused by the underlying illness. There may be some tiredness, some fatigue, a tremor may occur, and headache. People commonly complain of headache. I don't think that right here and now it's a terribly good idea to give you a long list of these side effects. But what I will do later on is to give you some sources of information where you can go and find these side effects for yourself, should you wish to do so. The best way to deal with side effects is to avoid getting them in the first place. And there is a mantra that I think every mental health pharmacist would be familiar with that helps with this. And that mantra is start low, go slow. So we start with a low dose of the drug and then we increase it very slowly. And in most cases, we'd start at a low dose with all of these drugs and maintain that low dose for at least a month. After that time, we would evaluate the effect that the drug has had, both on the dementia and in terms of side effects. And then we would take a step upwards if necessary, and again monitor for the effect on the dementia and the potential for side effects, and do it in this slow, stepwise fashion until either we've reached the recommended dose or the side effects are proving to be so difficult that we can't increase the dose any further, and we then make a decision about whether to try another of the medicines to try and avoid the side effects the person's experiencing. People are often concerned about how side effects should be monitored because, of course, health professionals won't be with the patient 24 hours a day, 7 days a week. The only person who's going to be with the patient over that period of time are the people who are living with them and caring for them. But it's not as difficult as you might think to monitor for side effects, and the best thing to do is to keep a diary. Ideally, we should give you a diary with the potential side effects, the common side effects, before you start the medicine, so you can have an assessment of what the person is like without the medicine, and then we're looking to see if there are any changes over time using a diary sheet. My biggest concern is the lack of investment in mental health services generally. It's been said many times that mental health is the Cinderella of the National Health Service. That is absolutely true. Money has been taken away from mental health services year on year for at least the past 5 or 6 years. And of course, within the context of mental health, the Cinderella of mental health is probably dementia care. So I would like to see much more investment in mental health generally and dementia care specifically. If and when new medicines arrive, the cost constraints in the National Health Service now are so great that there will be a reluctance to offer new medicines for the treatment of dementia because the likely expense is going to be high. Those are my biggest concerns. Most people with dementia are cared for in a community setting, most commonly, of course, in their own home, and the people who care for them don't receive any training whatsoever. I think there is an enormous case to be made for providing training for people who give this informal care to their family members. In terms of the health professionals and social care professionals who are involved in dementia care, it's not really for me to comment on their training, but from experience what I would say is their knowledge of medicines is often quite limited, at least in comparison with the knowledge of medicines that's available from a specialist mental health pharmacist. Most of the medicines that are going to be prescribed for these people will be prescribed by the GP, and they will be dispensed by the local community pharmacist. And of course, these people don't have specific training in dementia care. My advice would be that if you do have questions about the medicines that a person with dementia has been prescribed, it's certainly okay to start with your GP or your local pharmacist, but don't expect detailed answers from them because they simply don't have the training or the knowledge in order to be able to do that. What you can do is contact your local mental health care provider. You will have a mental health trust and usually a consultant who's in charge of your care, and ask there if you can speak to the specialist mental health pharmacist who'll be based in the hospital and who'll be able to give you much more specific answers to questions that you may have. When it comes to medicines used in the treatment of dementia, I think there are two important sources. The first one is NICE, the National Institute for Healthcare Excellence. Now, people may think that because NICE is operated by the health service, it's something that's there for health professionals, but that's not correct. NICE is an open access website. Anybody can access information on NICE. Any of the information that NICE produce is available to everyone. They do have a range of clinical guidelines and a range of information booklets for carers of people with dementia. The website is www.nice.org.uk. The second source that I would suggest is a little bit more technical than the guidelines that NICE give. This is something called the Electronic Medicines Compendium, and you'll need to Google that, Electronic Medicines Compendium. And this is a source of information that is really intended for health professionals, but it is still open to the public. And on the Electronic Medicines Compendium, you can obtain information called the Summary of Product Characteristics, or SPC for short. And this is the information that the different pharmaceutical companies are required to publish by law for health professionals. Now, the information that it contains is a little bit, well, no, it's not a little bit, it's quite complex and quite technical. So you may need the assistance of a medical dictionary to understand some of the terms that it contains. But you can find medical dictionaries available free online as well. But this gives you the most up-to-date, accurate information about the medicines, about how they work, about any complications that may arise from their use, about the side effects that are likely to occur. So it's something that I do recommend, perhaps with a little trepidation, but don't be put off by the technical nature of it. It's a treasure trove of information about medicines. Sadly, of course, dementia is a progressive condition for which there is no cure. And it's inevitable that sooner or later the person affected is going to reach the end stage where they no longer care for themselves in any way whatsoever. At this stage, palliative care is what is offered to people. The purpose of palliative care is to keep people as comfortable as possible and to maintain their dignity as much as possible. As you might expect at this stage of care, there are no clinical trials. It wouldn't be ethical to conduct clinical trials in people at this stage of their illness. So you have to ask the question, is there a role for the use of medicines? And the answer, of course, is yes, there is sometimes, not always. And medicines can be used in the same way as they're used in other conditions where palliative care is needed. For example, to control pain, if it's obvious that the person is in pain. Medicines are sometimes used to also try and control behaviours that make life difficult or are distressing for the person involved. There is very little evidence to guide clinicians in which medicines should be used or how they should be used. So we come back to this mantra of start low and go slow. Any medicine that might be used to try and control these distressing behaviours would start at a low dose and would be increased in dose only gradually. And if it wasn't having an effect, and if it was clearly causing problems with side effects, then it would be withdrawn. The kind of medicines that might be considered are medicines called antipsychotics, which are often used for the treatment of conditions like schizophrenia or bipolar disorder, but which may be used in dementia because they do also have calming properties. Sometimes they work, sometimes they don't. Sometimes medicines that are used for the treatment of epilepsy might be tried. Medicines like carbamazepine or sodium valproate. NICE actually says there is no evidence to support the use of these medicines. But that doesn't mean it's not worth trying, because it might be that an individual has a response that wasn't seen in a clinical trial. And our list of options here is very narrow, very limited, and it's sometimes worth a try rather than leave a person in distress for an indefinite period. It's not good news, I'm afraid, use of medicines in end-stage dementia, but that's why you have consultant psychiatrists, mental health pharmacists, and mental health nurses, all trained in the management of end-stage dementia, on hand to try and make sure that the person is kept as comfortable as possible in as dignified a manner as possible.